Testing 1, 2, test, test. 1, 2, test, 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 test. Test 1, 2, test. Testing 1, 2, test, test, test. Test, test. Test 1, 2. Test, test, test. Testing 1, 2. Test, test, test. Testing 1, 2, test, test. Test 1, 2, 1, 2. Test 1, 2, test, 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 test. Testing 1, 2. Test 1, 2. Test, test, test. Test 1, 2.
Afternoon. If everybody's good, we'll go ahead and get started. My name's Kirk Withrow. I'm from UAB. I'm one of the otolaryngology faculty there. Speaking today about diagnosis and management of obstructive sleep apnea. A lot of the management part I'll touch on, of course, will be surgical. No disclosures, but a disclaimer. I'm not a sleep medicine doctor, but treating any patient with sleep apnea, we have a fairly significant amount of sleep medicine that's involved, but primarily I'll talk about surgical applications. We'll start with just an interesting kind of evolutionary perspective on why there's sleep apnea or snoring to begin with. But an interesting article that kind of ties the development of snoring and sleep apnea to the acquisition of speech. Most animals don't have any issues with sleep apnea, but of course animals can't talk, and so it was the change in the loss of this epiglottic palatal lockup that allowed speech, but then also led to more crowding of the oropharynx and development of sleep apnea. As it relates to sleep apnea, we have a more posteriorly situated tongue, that essentially resides in the oropharynx, and the narrow and elongated respiratory tract, which is prone to collapse. So the longer it is, the more collapse that you have. And so the kind of a trade-off for being able to talk led to a higher prevalence of sleep apnea, as well as quite a few other things: risk for aspiration, issues with intubation, impacted molars, chronic sinus issues. So a lot of negative things came with the acquisition of speech. So briefly, I'm going to talk about the symptoms, health consequences, and diagnosis of sleep apnea, as well as a little overview of non-surgical treatment of sleep apnea, which happens, mostly before we see patients, although we do send them back to that therapy as well. And then what happens when we start thinking about sleep surgery, how we go about deciding, what to do, and some of the options that we have for treating people who cannot use a CPAP or BiPAP or what have you. So we have a lot of different types of folks in the audience, so I'm going to briefly describe sleep apnea. Basically, it's just recurrent collapse of the airway during sleep when you lose muscle tone. You can either have complete cessation of airflow, which is apnea, or a partial cessation of airflow, or simply a reduction, which is a hypopnea. These will result in hypoxemia, hypercapnia, sympathetic activation, sleep fragmentation. You'll start back to breathing, and it's a recurring cycle throughout the night. And you see something along these lines. If you lay down when you're awake, you have a patent airway, but with the loss of muscle tone that happens in sleep, both non-REM and REM sleep, the tongue falls back, the palate falls back, and you can have obstruction for various reasons that we'll see in a minute. Symptoms of sleep apnea, most everybody's pretty familiar with. Snoring, sleepiness during the day, impacts the job performance, impacts quality of life, headaches, particularly in the morning, and cognitive dysfunction. Some of the health consequences: hypertension, increased risk for heart attack and stroke if the severity of sleep apnea is high enough, depression, and early demise, again with a certain amount of sleep apnea. There are other issues there as well, again to quality of life. Snoring just by itself, 25% of of couples over the age of 40 sleep in separate bedrooms because of snoring, and there's a 3-time increased risk of divorce in patients with sleep apnea and hypersomnolence. So it has a lot of impacts outside of just your health issues. It's a common problem. 25 million Americans, estimated that a quarter of adults 30 to 70 have sleep apnea, and the majority of those are undiagnosed. So they don't even know they have sleep apnea, or maybe they do, they just haven't been tested. But so it's always important, regardless of where you're encountering patients, to realize that maybe they have sleep apnea and they've not been tested, because that can have significant impacts for surgical patients or medical patients as it relates to their other comorbidities. It's an expensive problem. Pretty significant costs that they attribute to untreated sleep apnea. As it relates to some of the other medical problems, it's very expensive. Even car accidents. If they estimate $60 billion from drunk driving accidents, and almost half of that they'll also see related to sleep apnea related or hypersomnolence related car accidents. So significant issues as far as not diagnosing and treating patients with sleep apnea. They're not always easy to pick out. I mean, there's certainly stereotypical patients with sleep apnea, morbidly obese, sound like they're snoring when they're awake, and but you can have patients who are underweight who have sleep apnea. So sometimes just looking at it is very difficult to tell. You can have skeletal issues like this guy might have, and you can have weight issues there, and they can both have sleep apnea. And the treatments, of course, are going to be different if you're looking at surgery. So as far as risk factors, males are a lot more likely to have sleep apnea until menopause, and then the risk for females goes up some. African and Asian descent, certainly increased body mass index, obesity increases your risk for sleep apnea. Other family members that have sleep apnea will have a bearing, because of skeletal issues and things of that nature. And this kind of ties into some of the anatomic factors, but retrognathia and congenital problems would predispose a person to sleep apnea. So there's some things you can do initially to see. A very easy thing is either initially it was a stop questionnaire or a stop bang questionnaire that is fairly sensitive for severe apnea and even fairly sensitive for mild apnea, just not as much so for severe. But there are 8 easy questions that you can ask and have a pretty good idea of how likely this person is to have sleep apnea. As far as the stop questionnaire, do you snore loud enough to be heard through a closed door? Tired during the day? Has anyone told you stop breathing? Do you have high blood pressure? There may be people in here that I got sleep apnea that haven't been tested. Then you can add, to get a little bit more sensitivity, the bang questions, which is a BMI greater than 35, older than age 50. Neck circumference is certainly a little harder to measure unless you are have a tape measure in the clinic or something. But a neck circumference greater than 16 in a female or 17 in a male. So in a male, you can just ask them their neck size, and they may know that, and you can have a pretty good idea. And then gender, being a male, is going to put you at a little higher risk. So 2 or more on just the stop questions is high risk, and 3 or more in the stop bang questions is high risk. So that's enough to make you consider sleep apnea, and if need be, send them for a referral to a sleep study. The gold standard is an overnight sleep study, polysomnography. A lot of different channels of data, a lot of different wires there, but that gives you the most information. Other newer alternatives in some patients, it's a home sleep study. Not quite as much information, very well validated against an in-lab study, but a lot less cumbersome and easier for some patients, particularly if they're high risk. So if they, have 3 positive answers on the stop-bang questionnaire, they don't have bad COPD, they don't have congestive heart failure, and you're not worried about central sleep apnea or something like that, then that may be a good option. The diagnosis of sleep apnea is largely made with the Apnea-Hypopnea Index, which is the number of apnea and hypopnea episodes divided by the amount of sleep time. It's an interesting number because a lot of emphasis gets placed on it. It's kind of a man-made number, with normal being 5 or less events in an hour. Mild to moderate is going to be between 5 and up to 30, and then severe is above 30. There's not a lot of correlation with that particular index with symptoms that a person has. So before I came here, I saw a patient with an AHI of 75 in clinic this morning. He's not sleepy at all. And then we'll see others with an AHI of 10 and they can't stay awake. So there's more to it as far as symptoms, but a lot of the diagnosis and treatment success is based on this number. So as far as treating it, the gold standard is CPAP, and it works extremely well. It's non-invasive, but the problem is the compliance, and it's like most medical interventions, it's about 50%. So 50% of the people will tolerate it, and 50% won't for all sorts of reasons. And so the first thing that we do, I do in my clinic, because I'm seeing patients who are coming to try to get surgery or another option for treating their sleep apnea is figure out why, because there's a ton of reasons why they don't tolerate it, and some of them are not good. Sometimes they're like, oh, I just didn't want to use it. It looks annoying or something. And so, sometimes it's just talking to them and they're like, okay, I'll try it and see. Sometimes it's nasal obstruction. Sometimes they've legitimately tried everything under the sun and they just can't tolerate it for all sorts of reasons. But it's definitely the first thing to try, and we send a lot of patients back to try it to make sure before we say, all right, you can't use that therapy. There's a lot of different masks. You have in general, the smaller the mask, the better tolerated. So nasal pillows, something like this, overall is thought to be more tolerated than just a nasal mask or a full face mask. But the truth is, whichever one they're going to wear is the one that's the best for them. And sometimes it's trying all of them before you find the right one, because everybody's face is shaped differently. Some of the things you can't get around as easy. Nasal congestion, a lot of times if that's the problem, we'll just treat that, whether it's with a nasal steroid or maybe nasal surgery, which isn't going to have a huge impact on their sleep apnea, but might make them from a CPAP intolerant patient to a CPAP tolerant patient. Claustrophobia is one that is sometimes harder to treat. The sleep doctors will often give medication to kind of help during the acclimation period to see if they can become okay with that, but doesn't always work. But and then air leaks, which sometimes is just a mask issue. Sometimes it's a pressure issue, and we can do surgery to decrease the pressure and again go back to CPAP. One thing that I've always found interesting is the issue of what is enough as far as CPAP goes, and in general with compliance, 4 hours a night for five nights out of the week is kind of what is considered to be good compliance. And but what you see in studies have looked at it, 4 hours a night you'll get improvement in the Epworth Sleepiness Scale, which is kind of the most common scoring system to look at just the daytime hypersomnolence. Multiple sleep latency testing scores take 6 hours a night, and then a functional outcome of sleep questionnaire, which is a little more cumbersome quality of life metric. It takes 7.5 hours of CPAP a night to get that back to normal. And so those numbers are important for later on when we talk about the upper airway stimulation treatment. Other non-surgical options, an oral appliance can work for the right patients. Most of them are what's called a mandibular advancement device. So they're just moving the lower jaw forward. Obviously you have to have enough teeth to hold that. So an older edentulous patient's not going to be a great choice. It doesn't work in everybody. There's issues with tolerance of that as well. TMJ problems are often going to be aggravated by that because this lower jaw is getting pushed out and held there, for a long period of time. And it can change your occlusion. It can shift your teeth over time. Much less common looks like an adult pacifier, but it's a tongue retention device that actually pinches the tongue and holds it forward. I've never seen a patient that uses one of those, but there are types of oral appliances like that available. And then about the only other non-surgical option that I'm aware of is something called Provent, which is nasal EPAP. Now, I've very few patients I've seen that have used that, but the ones that do with fairly mild apnea can get probably as much improvement as with an oral appliance. But the principle of that is that it's kind of like a partial one-way valve. So they breathe in, you can see all the air comes through. When you breathe out, it closes down, so the back pressure opens the airway up. But it's just a sticker that goes over the nose, so it requires breathing through the nose and some getting used to. This guy looks thrilled with them, but that's an option if you have somebody that isn't interested in surgery or you're trying to avoid surgery and you're not able to get them any relief with CPAP. Now, sleep surgery, I think, is an interesting thing because I think, relatively speaking, a lot of it is fairly recent. The UP3 was one of the main surgeries initially done, and it was like in the 80s, the early 80s. So even that wasn't that long ago. But I think that for probably up until the last maybe 5 to 10 years, it really didn't get much better, much more scientific. So I think that we could do things and we could, have success, but I don't think we did a great job. And I don't think sleep surgery is perfect, but I think it's getting much better as far as the way that physicians who are doing sleep surgery are approaching patients. And so the first thing is in my mind is there's certain things you have to keep in mind with sleep surgery, and probably the main thing is with exploration of patient goals and motivation. If you have somebody that comes in and they've been using CPAP successfully for 10 years but decided they don't want to use it anymore, it's maybe not the best person to do surgery on. They've got an established treatment that's working really well, and you're not going to beat that probably. So really making sure that you're just not doing surgery on everybody that shows up just because you can do surgery, but figuring out if that's their best option. And then at that point, it becomes important to figure out where the collapse is happening and what pattern it's happening in. If you can imagine CPAP, it just blows everything out of the way. If it's the tongue, the tonsils, the palate, the pressure moves everything. It doesn't even matter for most people where that collapse is happening. But with surgery, it definitely matters. If you have a patient that has epiglottic obstruction and you do a palate surgery, you haven't probably fixed anything and probably caused problems. So that, I think, for the longest time in sleep surgery was a big problem, is not being able to figure out exactly what target we're looking at. And then once you are able to do that, figuring out which procedure is going to treat that. And then more important than any of it is a realistic goals. And I'll go back to the patient that I saw this morning. He's tried CPAP, he's on BiPAP, he's got a severity of his sleep apnea on BiPAP is 25. He started at 75. He can barely tolerate it. And so he said, well, if I do surgery, is it going to fix it? He's fairly overweight, so no, it's not going to. There's no way you're going to get rid of it with surgery. You could probably get it down to 15 or 20, which if you're considering going from 75 is a significant improvement. You can definitely offset some of the health consequences and symptoms, but I'll see patients that had a palate surgery and they say, well, the doctor said I was going to be good, I was never going to need a CPAP again, and they're maybe the same as they were, sometimes worse, and that's just, even saying that, it makes no sense. There's not a surgery that, and even if you fix it, it's not going to last forever most likely. So you just have to make sure that as the doctor you accept that you can't fix it. It's a chronic problem. You can treat it and make sure that the patients understand that as well, and they're going to be much happier. So figuring out, what is success in surgery kind of comes back to how you're going to define it. There was a study in the sleep literature that, kind of said sleep surgery doesn't work, and part of that comes down to who's talking about it and how they're defining it. And so if you have sleep apnea and they titrate you on a CPAP, their goal is to get you to an AHI of 5 and under, back to normal, which is fantastic. And they can do that pretty frequently with CPAP. And so that's how sleep medicine defines success with surgery. Sleep surgery literature has a million definitions, but the most common is a 50% reduction in the severity of your sleep apnea and getting you below 20. Oral appliance literature uses an AHI of less than 10. So there's a lot of ways you can define it, and it comes back to the expectations and the goals. But depending on these definitions, overall, with the surgery literature definition, about 50% of the time you can hit that in what's published. You get a little more strict and you're at 30%. If you want to look at getting a patient below 5, it just doesn't happen very much. That doesn't mean it doesn't help them, but it's not getting them down to a normal range. So it comes down to what the patient should expect. And it, in my mind, comes back to, there's a table missing there, but the chart that was there, looking at CPAP compliance, and as I mentioned in the beginning, overall in most studies it's about 50%. And it's the 50% that aren't using it that we're primarily talking about. And if you're not using it, then your success is 0. So surgery can definitely offer an improvement beyond that. So it's not a cure, as I mentioned. It's not a replacement for CPAP, and we can use it as a sole treatment or as an adjunctive treatment to CPAP or an oral appliance. But as far as what we do with surgery, I talk to patients about 3 kind of main categories of surgery or ways to treat it. We can do soft tissue surgery, which is probably the biggest category. It's removing tonsils, tonsil tissue off the back of the tongue, repositioning the palate, stabilizing the tongue, anything that's changing the muscles and the lymphoid tissue in the throat. Orthognathic surgery, maxillomandibular advancement, which is very effective but sometimes hard to sell patients on. And then the more recent and I think one of the more exciting treatments is upper airway stimulation, which is a nerve stimulator to treat the collapse there. So we'll go through some of these options that we use and some that we don't. I'll just breeze past. But here's kind of an incomplete list, admittedly, of a lot of the things that can be done for sleep apnea. So there's a ton. Some things are never ever done, like a laser-assisted uvulopalatoplasty, pretty much gone by the wayside. But some of these are still done, but you can see it's very difficult to figure out which of these is right. And there are patients that will benefit from every one of these. It's figuring out which ones match up. And so it becomes an issue of, like this guy is just going to get a little bit of everything, and you'll see a shotgun effect like this where, if you try enough things, you're eventually going to get something that hits the target, but you don't want to be the target. You want to have the best procedure that's going to give you the most improvement. And so that's one of the biggest changes I think in sleep surgery is not just trying whatever procedure on every patient that walks in the door, but really looking to see if we can improve our preoperative localization of the problem. And that comes a little bit out of this SHARE study that showed, probably the big takeaway from it is this bullet point here. The primary cause of surgical failure is failure to identify the site of obstruction. And so from there, you had a pretty significant push into a lot of things to look at how can we better localize the problem. And one of the more common things done, certainly in the States, is drug-induced sleep endoscopy. And we do that on the majority of the patients, unless it's a very straightforward situation where we just take out the tonsils, to look at how things are collapsing. And it is about a 20 or 30 minute procedure, usually with propofol, though you can use some other drugs. And it has some real benefits. You get real-time information. During that procedure, I can move the jaw forward and kind of simulate an oral appliance to get an idea if it's even worth the patient spending the money to try that. If we push the jaw forward and it doesn't help at all, then there's no reason for them to try to see, to spend $2,000 on a device. But we're also seeing dynamically the airway collapsing, and during a sleep state. We can do a flexible scope in clinic, and we can get good information from that, but they're wide awake, so they have all the muscle tone, so you're not seeing truly what you want to treat. And so we miss out on some things, particularly when it relates to the tongue and the epiglottis. The tongue is a very strong muscle, and you almost can't generate enough pressure to get that to collapse unless you don't have the muscle tone. So there's some significant benefits there. And what we do is we use a scale. Probably the one that's used the most and the one that I use is called the VOTE scale. So we look at the palate, the oropharynx, the tongue base, and the epiglottis, and you grade where these collapses are happening. Not only do you do that, but you grade how it's happening. There's been a lot of studies that show, for instance, at the palate, if you have an anterior and posterior collapse, which just means that the soft palate falls straight back against the back wall, that's a much better situation than if you have a concentric circular collapse where the airway collapses more like a sphincter. And that's partly because we have a better ability with surgery to hold tissue forward than to keep the lateral tissue out, and it's harder to stabilize that. As far as the tongue base goes, it can collapse in different ways, and there are, I think, different treatments that are going to be more effective depending on what you see there. And then the epiglottis. And as far as the tongue goes, if you have the epiglottis back here, the back of the throat here, the tongue here, and in blue is the lingual tonsils. If you have a situation like here where we have what we call a retroepiglottic collapse, meaning the back of the tongue is pushing the epiglottis back, a lot of times that's because of a lingual tonsil, and using a robot, taking that out will help. But if you have a supraepiglottic collapse or a high tongue base, the lingual tonsil tissue isn't moving at all. It's the tongue falling back over the top of it. So if you go and take this out, you're probably going to make no difference because it's the top of the tongue that's falling back. So we would tend to use a different type of a procedure for that. So it allows us to much better tailor the surgical treatments to an individual patient. So with all of the push towards trying to have a better ability to localize it, there have been a lot of studies that look at the outcomes as it relates to it. And with sleep endoscopy, there have been plenty of studies that show in quite a few situations here improvement in outcomes. So there are several studies that look at palate surgery, even multi-level surgery, which generally means palate surgery and probably some type of a tongue surgery, if not a hyoid surgery, which we'll talk about in a minute. You absolutely have to use it for the nerve stimulator that's currently available, and we'll talk more about that. And then again, there's data to show that the improvement with a jaw advancement correlates with outcomes in patients who use a mandibular advancement oral appliance. So not only do we get information, but it does yield improved surgical outcomes. Let's see how good it's going to play. So this is a video of a part of a sleep endoscopy. It's, there's bubbles, everything else, a lot of things in the way because they're actively breathing. But the back wall of the throat's here. This is lingual tonsil, and that's the epiglottis. So you can see active breathing, and you can see the epiglottis, pulling down. You'll see, the same type of thing where a patient obstructs, and you see 4 or 5 attempts at breathing before they finally get enough sympathetic activation and start back to breathing. So you're basically watching what's happening during those events that you're seeing on an overnight study, and from a standpoint of a qualitative look rather than a quantitative evaluation of, say, the severity of apnea. So what we learned from that, I've already gone over most of this, but we use it to see if somebody's a candidate for a hypoglossal nerve stimulator. We can use it to develop a soft tissue surgical plan and evaluate for an oral appliance. If we have a patient that we're considering maxillomandibular advancement, you don't really need a sleep endoscopy because that's changing the skeleton, so you don't need to see as much the soft tissue collapse. And depending on what we see there, this is more or less what I will do based on those results. So if I have an anterior and posterior collapse, I'll do a procedure usually called a zetapalotoplasty, and a concentric collapse or significant lateral wall collapse, we may use an expansion pharyngoplasty. Depending on how the tongue collapses, as I mentioned before, we'll do a lingual tonsillectomy or a base of tongue suspension. And then for the epiglottic collapse, we'll do a hyoid suspension. And I'll go through these briefly in just a second. And then there's the possibility of a nerve stimulator. So to go back to basically the first sleep apnea procedure, again, it was in early 80s, and it was the UP3. And so at first, that's all that we had, and it worked okay. It didn't work great, and it has a lot of complications. The main ones, potential for VPI, stenosis, pharyngeal symptoms with just the feeling of something stuck in the back of the nose is pretty common. And the issue with that is largely the forces of healing kind of direct the palate to the middle and posteriorly, which is not ideally what you want. And so this study back in '96 showed a 39% overall cure, so again, not great. And then perhaps more significantly is at 3 to 5 years, you've got up to 40% of patients that still have problems. And I usually explain that a lot like a facelift to patients, because if you do a facelift, you may get a great result, at 6 months, but in 5 years, it's not going to look as good because you're just moving the soft tissue, whether that's with scarring or repositioning the muscles, but the tissue stretches again, and you lose some of that benefit over time. So that's a definite drawback to a lot of soft tissue surgery is it's not likely to last forever. The zeta palate has some significant improvements over traditional UP3, and this probably is not all that interesting to a lot of people that aren't doing surgery, but the main difference is when you are doing this, the scar is on the oral surface of the palate, so it's not pulling the palate backwards, and the force is directed to the outside, so it pulls the palate forward and laterally, so in a much more favorable direction. And studies that have looked at this and compared it and show pretty significant improvement over a traditional UP3, not only in objective measures, basically AHI improvement, but quality of life scores and less overall complications or long-term issues with it. And I think that's primarily because you're not having a scar on the free edge of the palate, but rather on the oral side of it. If we have lateral wall collapse, this procedure does a much better job of addressing that. And basically, already in this picture, the tonsils have been removed, and you have muscles that bound the tonsils on the front and the back, the anterior and posterior side of it. And we use the posterior muscle as essentially a buttress and divide that and suture it out, which holds the lateral walls out and stabilizes it. So you get a much improved result if they have a concentric collapse or lateral wall collapse than you would with either a UP3 or a zeta palatoplasty. And again, the studies that compare the two show a pretty significant benefit over a traditional UP3 as far as the overall treatment benefit. And we start talking about hypopharyngeal procedures. Hyoid suspension is pulling the hyoid forward here towards the jaw, and it widens the retroepiglottic space by the attachment of the hyoid to the epiglottis. And then a tongue suspension is basically a stitch that serves as a static sling that stabilizes the tongue and keeps it from collapsing. Lingual tonsillectomy is just that, taking out the tonsil on the back of the tongue. Most of the time, if we're going to do that, we're going to use the robot simply because it's difficult to get back there and adequately visualize and instrument that area because of the location. And overall, the data for most of those surgeries is not great because a lot of it is unselected patients. They if they are studying genioglossus advancement, they're going to do it on all the patients without a lot of input, say from a sleep endoscopy or another study, because they're older studies. But overall, multi-level surgery outcomes, range probably in about the 50% percentile. More historically, now some of the newer studies are maybe in the 70% improvement, but still not near, getting a patient down to an AHI of 5 as you would hope with CPAP. Much more recently, say in the last maybe two and a half years at UAB and 5 years or so overall, there's been the availability of upper airway stimulation or a hypoglossal nerve stimulator. That is a device that has some very significant benefits compared to our other surgical options. Has 3 components. There's a small lead that goes between the ribs that detects breathing. There's a generator, like a pacemaker, that sits over the chest wall, and then a small lead that goes to the hypoglossal nerve. It's a procedure that it doesn't change anything permanently, so we're not injuring the throat, so it's far less morbid. With the soft tissue surgeries, I tell people to clear their schedule for about 2 weeks because it's pretty rough. With this surgery, most patients will go home that day and they just don't have a lot of trouble. There's not a lot of pain with it. The downside is it's not something that you can use for every single patient. Afterwards, there's and this is not one of my patients, but there's a small incision there, small incision there. They have a remote where they can turn the device on at night or before they go to sleep. The patients that are eligible for it, CPAP intolerant patients. So if they're not treated, then we can consider it. BMI considerations in that the original study looked at a BMI of 32 and under. And so that was the original cutoff. When the FDA approved the device, they did not establish that as an absolute criteria, but the chance of it being a good option starts to decrease as your body mass index gets over 32, which is still fairly high, but moderate to severe sleep apnea, the FDA labeled it for 15 events an hour to 65 events an hour with 25% or less of central sleep apnea. In other words, that's when your brain is not telling you to breathe. You're not breathing, but it's not because you're obstructing. It's just because there's no effort. And then on a sleep endoscopy, we learned at the STAR trial, which was the original trial that resulted in FDA approval, that patients who had a concentric collapse didn't respond as well. An anterior-posterior collapse was no problem, and that's because of the coupling of the soft palate to the tongue, such that when the tongue pulls forward, it'll pull the palate forward, but it can't open the side walls very well. So the original STAR trial was 22 centers, 126 patients. Again, the BMI was 32 and under. Most of the patients finished the study, and in that trial they had a 70% roughly reduction in the AHI, so from about 30 down to 9, and a decrease in the oxygen desaturation index of about 70 as well, so from 25 episodes of desaturation to about 7 or so. The other things that they looked at of note was they measured the Epworth Sleepiness Scale and had normalization of that, as well as normalization of the functional outcome of sleep questionnaire, which, if you remember back to the original slide, with CPAP, that was 4 hours a night for the Epworth and 7.5 hours a night for the functional outcome of sleep questionnaire. So it definitely has a significant clinical benefit to the patients in addition to the objective improvement that we saw in a sleep study. Most of the patients now go home the same day. In the study, most of them went home the next day, but very few stayed more than 1 day. A lot of those that did were over in Europe, where they were required to stay 1 to 2 days in the hospital. So the other thing that I think is very important about this therapy is that this study was 5 years ago, the original STAR trial, and we have data now out to 5 years, and the benefit that we saw at 6 months and a year is the same or better than it was initially. So it doesn't seem to fall off. The improvement is something that seems far more durable than what we see in most of our sleep surgery. There's, with any treatment of sleep apnea, potentially if you improve the sleep apnea, you're going to improve the snoring, and that was addressed by basically a bed partner questionnaire, and the vast majority of the patients either quit snoring or it was not an issue. So our experience with this treatment, we do it at UAB, we've started at the VA as well, and have 70-something patients that we've used it on. The procedure takes about an hour and a half to do. It's under general anesthesia. Most of the patients will go home the same day, and so that's one of the big differences is excuse me, is the morbidity. So there's just not much pain with it because we're not injuring the throat. So significant decreased need for narcotics. Almost no patients need it. And then after the fact, it's very well tolerated. We see about, I think it was 49.8 hours of use per week, which is probably the majority of a person's sleep time. And then as far as looking at our AHI improvement, it's around 90% on average. And if we look at it in terms of how much improvement, our first 25 patients we've submitted for publication, but we got 83% less than 5, 92% less than 10. So our mean AHI to start with was 37, and our average afterwards was 3.9. So it's very, very much more favorable than our other surgical patients. And then maybe the last thing that I think is important is the mean age of our patients, primarily because of insurance issues. Medicare will cover it. Blue Cross of Alabama puts up a lot of a fight. But the age of our patients was almost 68. And other surgical literature as far as sleep apnea goes shows that you don't get as much improvement in patients who are above the age of 60 with surgery for soft tissue on sleep apnea, and you have higher complications. So we don't seem to see that with this device because it's you can't say it's non-invasive, but it's far less invasive than the other surgical procedures that we can offer. So that is a significant upside in this device. The current device is, originally it was not MRI compatible. The current device is MRI conditional, which means you can get head MRIs, extremity MRIs. I just think you can't get maybe chest MRIs, that type of thing. So it doesn't have as much limitation as far as the MRI constraints, similar to some of the newer pacemakers. So in conclusion, everybody knows sleep apnea is very common. It's definitely costly. It's something to look for in pretty much every patient, and they don't have to have a sleep study to be able to, to have a good idea that, maybe this patient has sleep apnea, and you can consider referring them if needed. And then in my practice, what I think is one of the more important things is, if someone has sleep apnea, they don't see the sleep doctors every single month. They see them once a year, twice a year, and a lot of patients have sleep apnea and are not being treated. And so ask them about it, figure out why, send them to whoever, and see if you can get them back on their CPAP or figure out some treatment, because a lot of patients there are options for them that and they're being untreated. So that's what I've got for you guys today. I'll be happy to answer any questions or thoughts. Yes, sir.
In your operation for the epiglottis and soft palate,
Yeah.
did you run across any cases of pharyngeal, nasal reflux with ED?
Very rarely. In zeta palatoplasty, I've probably done 100, 150 maybe, and I've had one patient that I had to surgically address that because they had nasal regurgitation. I've never had any other patients that had it beyond, say, a month or two. Now, the caveat to that's a water fountain. They lean over to drink out of a water fountain, it's probably going in their nose. But as far as regular eating or drinking, no problem, except for that one patient. So it does happen, but I think it happens a lot less than it does with the UP3 because the palate doesn't seem to get as tethered and scarred because of the injury being on the oral surface. It still moves pretty well, and we don't resect a lot of palate. It's more of pulling it forward rather than shortening it. So it's not a big issue. Any other questions? All right, well, thank you very much.